So these are the basic issues. We've been discussing them. Accuracy and reproducibility. There's no recommended standardization on the method of carotid IMT for clinical trials. In fact, a lot of different methods are used in clinical trials. And there are too many clinicians doing this measurement without proper training or equipment and receiving the reimbursement for it. So we can have the next. So I'm going to address the issue of certification and accreditation, and I'm going to address these three things in the next 3 minutes. Go back one, please. Is there consensus among experts in IMT certification and accreditation? Should reimbursement be tied to certification? And should IMT certification and accreditation come from a single organization or single standards? Next. So the first question is there consensus among experts in IMT certification and accreditation? And my answer is I doubt it, because if there was a consensus, then the clinical trials that we see, the 9,000 papers on carotid IMT, would all use the same technique and not a different technique. And in clinical practice, there's even more non-validated methods used, like pulling up a common carotid artery from one angle one time, a different angle the next time, and hand measuring the IMT difference. Next. So this paper was just published, and this is a very interesting paper for two reasons. The first is that this showed that the only cardiovascular risk factor that had an impact on carotid IMT was the latitude at which the people lived in. So the higher the latitude, Finland, the greater the IMT thickness, the lower the latitude, the less the IMT thickness, and correcting for all other cardiovascular risk factors, this held up. So take a look at this paper. But for our purposes, this is the technique that was used. The far walls of the left and right common carotid bifurcation and internal carotid were visualized, and the anterior, lateral, and posterior projections and recorded on videotape. And then it was reviewed in a centralized laboratory, which I think is imperative for reproducibility, and dedicated software. So the software is probably different. The approach is different. You can change your IMT if you go posterior to the sternocleidomastoid, if you go anterior, and it's different whether you're in the common carotid, the bifurcation, or the internal. Next.
Okay, we're going to come back to this slide. I haven't seen this study. Valentin also wants to discuss that with you, so we'll come back to this study.
Okay.
Yeah, go ahead.
Should reimbursement be tied to accreditation? Should be tied to certification and accreditation? Absolutely. If you look at vascular ultrasound right now, there are just too many people doing this who are not qualified to do it. They're getting reimbursed for it, and their results are not standardized ways of reporting or of doing the study. So I think that this should be a must if we're going to consider reimbursement for this. Next. Should IMT accreditation come from a single organization? Well, I've separated certification, and this is my definition of it, a method to demonstrate that a person performing and or interpreting the test has a basic knowledge of the proper methods of measurement and interpretation, so to make the technique and its interpretation accurate and reproducible. And accreditation is a laboratory within which one performs this technique meets certain minimum requirements for expertise, accuracy, and reproducibility. Next. So speaking, so my opinion is that certification and accreditation should be from a single provider, not both of those together a single provider, but a single provider for certification and a single provider for accreditation. Look at vascular laboratories. Some, the American College of Radiology certifies them. Others, the ARDMS certifies. This is the most common certification or accreditation, certification body. And in some, neurologists certify. So these are all different criteria, and levels of expertise are different among different societies. Next. I would suggest using an organization that's already involved in this. ARDMS would probably be the best organization. They register vascular technologists, they register physicians in vascular ultrasound. For them to do this, they would have to have a separate category only involving carotid IMT. You shouldn't make someone doing this be able to do all the vascular tests. Or you could have a separate certifying organization and reinvent the whole wheel. Next. And accreditation, I'd be in favor of using something like the Intersocietal Commission for the Accreditation of Vascular Laboratories. They would have to add a 6th category to this. The 5 categories are extracranial carotid, intracranial carotid, renal and mesenteric, peripheral artery, and peripheral venous. The 6th category would be carotid intimal medial wall thickness. And that's it.
Great. So, how do you address this question that Michael Jeff responded very clearly, that you don't have enough registered vascular technician in every lab, and if you're going to adopt a screening, especially you as a primary care physician, you don't have that kind of ability to afford that. So he said an MD, a nurse, practitioner, the office staff who is qualified to be trained could do this if the technique is automated enough. How would you?
Well, I didn't address that because I thought Steve Feinstein was going to talk about this, but I think anybody can be trained to do this technique. It's not just that you have an automatic technique, but the measurement itself has to be done exactly the same way, from the same angle each time. So you need markers to make sure that you're at the same angle, insinuating the carotid artery. And if you're going to use people who don't have ultrasound expertise, then I would insist on distal common carotid artery far wall, because that's the easiest to obtain, and not use internal carotid or the ball.
And how do you comment about ASC's recommendation? American Society of Echocardiography.
What is their recommendation?
As far as
they have a protocol that combines assessment of flag and then IMT of the distal far wall at 3 angles. So you do a short axis and then you do a crack, and then you do the long axis anterior, middle, and posterior for the bottom of the
I think that can be discussed.
Yeah, we will circulate that. Again, as a reminder, we will have transcript from this meeting. We circulate it, and our plan is to publish it. So if we missed here, unfortunately we missed Steve Feinstein some of the key questions about how automated IMT analysis works and whether they're qualified according to a reproducibility that the FDA approves or standardized according to FDA protocol. Any comment, Gene?
Well, I think there's agreement in the field the automated method just don't work because of problems with artifact, etc.
Okay.
It requires a human being.
Is there any standard FDA protocol?
No.
There is none. And why not?
There is
Well,
exception.
just like any other test, why not?
Well, they give an approval for instrumentation, not necessarily.
Well, that's instrumentation. It's an ultrasound. You can do anything with it. But what about the IMT? Is there not any FDA approval for that?
No.
No. Okay.
There's an analysis package approved, it's semi-automated. University of Iowa, they did their FDA approved semi-automated analysis.
So FDA approves software
Yeah.
for.
We also have another one that I know of that's
No, there's several. Yeah, there's not just.
Yeah, there are several companies
There
that
is
provide.
another ultrasound machine that has FDA approval. I don't know about Sonosite, whether you have FDA approval.
Sunsite has an approval of equipment, I believe, and also the software has received FDA clearance, not approval.
Okay, is that, so there is an FDA approval process for that, for carotid IMT ultrasound. Is that right, from the industry?
It's not a protocol.
It's not a
It's
protocol.
approval of the device and the software. It's not
Okay.
clearance, not approval.
What about the automated package? Is that does that come in within that whole category, or does that require a separate approval? Because
The
in my
software
mind-
has to be cleared also by the FDA, not approved, but cleared.
Okay.
All right, let's move on to Tasneem. Is certified vascular technician needed?